Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Consensus or Controversy, Current and Future Management of Ovarian Cancer. And today we're going to really focus on the future treatment of ovarian cancer. We have a great faculty today, Dr. Ursula Matulonis from the Dana-Farber Cancer Institute in Boston, and Dr. Debbie Richardson from the Stevenson Cancer Center in Oklahoma City, Oklahoma. As always, if you have any questions or cases you'd like to run by us, just type them into the chat room. We'll talk about as many of these as we have time. As we always do, we put out a quick little 1-minute survey for you to take before and after the meeting. It'll help you get more out of the meeting. It'll help us understand your needs better as well, so please take that. If you're into audio programs, we know a lot of people end up listening to our webinars, or they're driving their car or working out. We actually did a recent program on ocular toxicities in patients receiving anti-cancer therapy, a topic very relevant to what we're going to talk about today in terms of ADCs. We do webinars all the time. Next week, we'll be working with Dr. Carey on our HER2-positive breast cancer series. And then we'll be covering multiple myeloma on November 15th with Dr. Matulonis' colleague at Dana-Farber, Dr. Paul Richardson. As we always do every December, we'll be heading out to the San Antonio Breast Cancer Meeting. We'll be doing 2 big symposia out there on Wednesday, December 7th on HER2-positive and HER2-low disease. The following day, on Thursday, we'll be doing a symposium on ER-positive breast cancer. And then, believe it or not, the next day we'll actually be in New Orleans. I'm not going to tell you how we're going to do that. I'm going to do 3 symposia, one on CLL, another one lymphoma, and then finally on myeloma. It should be a pretty interesting week. That's all going to be online for you to check out as well. But we're here to talk about ovarian cancer and particularly what might be coming up next as we move forward with this disease. And particularly one of the things we're going to talk a lot about today is something we've talked a lot about in general in our programs, Ursula, which is antibody-drug conjugates. I want to start out with you because this has really, over the last couple of years, become a big, big area in medical oncology and gynecologic oncology. And before we start getting into some of these new agents that are not approved, we just want to talk about some of the things that we've kind of been hearing about and docs have been hearing about over the past year. So, of course, one of the biggest stories has been in breast cancer, where now we have one antibody-drug conjugate compared to another one. So TDXD versus TDM1, gigantic difference, hazard rate under 0.3. Really a revolutionary study. And then also with TDXD, another groundbreaking study looking at HER2-low breast cancer, the big plenary presentation at ASCO, showing great activity even when it wasn't fully expressed. And Ursula, these are some generic issues that all the ADCs and a lot of the drugs in general have to deal with. And I guess one of the issues is the target. We started out thinking it's going to be very simple. It's a target. And then we see that some people have different levels of the target. Any thoughts about, that idea and your vision of how ADCs work, Ursula?
Yeah, so I think, this is a really interesting drug. We're starting to use it in GYN cancer. So we have 2 trials of trastuzumab deruxtecan. One is a biopsy study for patients who have some HER2 overexpression. And then trastuzumab deruxtecan plus olaparib, which is a phase 1 trial through CTEP. And it's an interesting drug. We've seen some great responses. And I think it's going to be important to test in ovarian cancer where the HER2 levels are actually pretty low. It's pretty common to have HER2 0, because now I've been testing patients to try to see if they qualify for this trial. But there are other cancers like endometrial serous cancer, which tend to have higher levels of HER2 expression. So again, an interesting drug for a hard to treat cancer, carcinosarcomas. So I think it's going to be an interesting drug in GYN cancers.
And also, Deb, it's an example of sort of non-tumor specific use of agents. It gets used in one disease where you have a lot of the marker and then brought into another disease, as Ursula was just talking about. This is a really wild graphic I found in a review article. Looking at ADCs, this one particularly looking at 2 anti-HER2, but also sacituzumab, approved both in breast and bladder cancer, being looked at in others. And you can see that what I really love about this, if you look at it, it shows, different, lung, breast, bladder, et cetera, really the idea that I see more and more, not just with ADCs, and I know, Debbie, you're into phase one, is, pan-tumor, the use of pan-tumor, particularly targeted therapy. We just saw the approval of dabrafenib, trametinib across all tumors. Any thoughts about that idea moving forward and how ADCs might fit into that, Debbie?
Yeah, I mean, I think instead of treating every cancer from where it started from, when you're talking about targeted therapy, what's expressed on the tumor itself, and that can vary from tumor to tumor. And I think it makes sense to try and go after, develop drugs that have multiple targets and can be used in multiple different disease sites.
So, of course, the one antibody drug conjugate that I'm aware of that's actually approved in gynecologic cancers is tisotumab vedotin in metastatic cervical cancer. Ursula, fortunately, we don't see that much metastatic cervical cancer, but this drug is approved, and I guess it's modest activity. This is one of the first drugs I started to hear about ophthalmic issues. Now you have them in many different agents. Any experience with this drug in cervical cancer, Ursula?
Yeah, so I think that it's been a really important step forward, and just because our patients with advanced metastatic cervical cancer haven't had that many options for them except platinum-based chemotherapy, maybe anti-PD-1 if they're PD-L1 positive. But Tiso is an interesting drug, and yeah, the eye toxicities can be managed. There's very explicit instructions that are in the package insert that the company provides, where the patient has to put ice packs on, keep their eyes cool, really to prevent the conjunctivitis that can occur.
So yeah, I've been telling some of the other specialties about the ice bag thing because they don't all do that. And to me, it makes a lot of sense. It's like, I guess, the alopecia, the cooling cap. Any thoughts about, Debbie, this issue of ophthalmic talk? We'll talk about that, of course, with mirvetuximab. But any thoughts about it? We hear people saying that patients get very, anxious about the idea, although it seems like it's generally, pretty not too complicated to control. Any thoughts about this new toxicity we're dealing with, Debbie?
Yeah, I mean, I think we have figured out some good mitigation strategies to deal with it, both from tisotumab and also Ursula is going to discuss mirvetuximab, but working with our colleagues in ophthalmology and even optometrists, coming up with eye drops and a regimen, we can actually prevent a lot of the adverse events and mitigate it. And most patients are able to stay on the drugs, which I think is the most important thing. So kind of discussing with the patient and then having a plan in place is very helpful.
So you see the same issue in myeloma. There's an anti-BCMA antibody drug conjugate, ophthalmic issues. We actually did a program last week where we showed patients, and we had a patient on there who, believe it or not, was on this antibody drug conjugate for 4 years. And, we said, well, what's the deal with the eye thing? You go to the ophthalmologist, no big deal. So, that's obviously not typical, but she did really well. Again, just a quick review for reference when we get to the ovarian material. But now we're seeing ADC's first line diffuse large B cells since last year's ASH meeting. Polatuzumab now being used. Relapse disease as well, LONCA-T as they call it, very effective ADC. ADC now part of first-line therapy, Hodgkin lymphoma, and particularly after this last couple of months, we saw finally survival data, which has now really established this as standard of care in most people's mind, or many people's mind. And then also in bladder cancer, bladder cancer has 5 lines of therapy approved in metastatic disease. That's what, oncology is nowadays. And one of them that gets in pretty early is enfortumab vedotin. But the thing about that that's interesting is how excited the GU docs are about combining it with an IO. And here you see a waterfall plot looking at that. And, when you think about it, that's like, in a way, combining it with chemo, which is something we do a lot, the standard of care for lung cancer. And speaking of lung cancer, a couple weeks ago, we were speaking with Dr. Yanni from Ursula's colleague about this antibody drug conjugate. Looks like it's not approved, but looked like maybe it's going to be second-line therapy now, believe it or not, after osimertinib, the EGFR TKI. So we'll see whether that actually comes through. But there's a lot going on. I can kind of remember before checkpoint inhibitors only came in 7 years ago, And around that time, there was a lot of excitement about ADCs in the literature, but now I think we're really seeing it come through. So let's talk a little bit about mirvetuximab, and why don't we start out with the clinical reality. This is a patient who got mirvetuximab on a clinical trial. Ursula, what happened with her?
Yeah, so she's a 68-year-old lady with advanced fallopian tube cancer and presented with vaginal bleeding and spotting. She had an IP port placed. Didn't do great on IP chemotherapy. Then went to IV chemotherapy. So she got her first upfront line with carboplatin paclitaxel. Interesting, she was found to have a germline PMS2 mutation. So she went on oral niraparib really because of the the open PARP inhibitor approval in this setting in June 2017, and this was being used as primary maintenance. She ended up starting at 100 milligrams today, briefly increasing to 200, but then actually started to have some of the toxicities that can be seen with niraparib because of the interactions with the norepinephrine receptor, tachycardia, hypertension. So then on niraparib, unfortunately, she started to have disease progression and had small volume ascites and peritoneal carcinomatosis. So then she started BEV and pegylated liposomal doxorubicin, received 3 treatments of PLD-BEV, but then developed significant skin toxicities and mouth sores. Her CA-125 continued to rise despite this treatment. I went back to carboplatin and gemcitabine. She received 6 cycles, had kind of a partial response, but then her C5 started to rise after the latter 3 cycles. And then she started on mirvetuximab, which was her treatment number 4, single agent, and stayed on treatment for 11 months before cancer progression. And her best response was stable disease. She had a 20% tumor reduction by RECIST 1.1. She really did quite well. She came from out of state to see me, so she would fly back and forth every 3 weeks for treatment. And she had, what we see is just grade 1 corneal microcysts, which have been called by the ophthalmologist, and that translated to grade 1 blurred vision, and then a little bit of grade 1 nausea. So she did really well.
So, I didn't notice in your write-up, PMS2 mutation. What is that? Is that like BRCA or something? I never heard of that.
Yeah, it was on her panel. I don't think it did much of anything for anything, but it was a germline mutation. But yeah, it didn't alter her responsiveness to chemotherapy at all.
Interesting. Anyhow, yeah. I'm curious, Debbie, how this course, I know you were involved with the first in human study with Katie Moore. I believe that was the case. So you had a lot of experience with this agent. Is this course that Ursula just described similar to what you've seen or different?
Pretty similar. Patients do often have a little bit of blurred vision and nausea, usually really manageable side effect profile, and patients really tolerate mirvetuximab quite well. And we've seen actually even quite a bunch of responses as well, which I think Ursula will get to. So I'm pretty excited about the data from mirvetuximab.
So, of course, our chat room's like the best ever. They're already trying to figure out what PMS2 is and et cetera. But we'll just try to stick. We'll try to stick with the script. So we're doing something today we don't usually do. We tried this last week and it worked really well. So we want to try it again, which is short mini presentations during our webinars. So Ursula actually submitted really very comprehensive review of mirvetuximab. It's in the appendix if you just of the slide set. So if you go in the chat room and download the slides, you'll get the entire thing. But we asked her to really summarize it in just a few minutes and talk more about mirvetuximab in general. So I'll hand it over to you, Ursula.
All right. Thanks, Neil. So, I'm going to talk about the SORAYA study, but certainly can reference other trials of mirvetuximab as well. And we know that our treatment options for our patients with platinum-resistant ovarian cancer, like the patient I presented, are limited and are predominantly single-agent chemotherapy once patients have received BEV, and the response rates are low response rates. Folate receptor alpha-1 or FOL1 has limited expression on normal tissues, but is elevated in most ovarian cancers, specifically high-grade serous ovarian cancer, and high levels of expression, that PS2 scoring, where you've got 2+ or higher scoring on more than 75% of the cells, is present in about 35% of high-grade serous cancers. The single-agent MTD of mirvetuximab is 6 milligrams per kilo, and Debbie and Katie Moore, and we participate in that study as well, and it's calculated by the adjusted ideal body weight. And then, so SORAYA is really it's called a phase 3 study, but it's not really a phase 3 study. It's more like a single-agent pivotal trial. It came after FORWARD-1, which was not a positive study, and we were really able to focus on high levels of expression, patients with high-grade serous with high levels of expression of folate receptor alpha. So mirvetuximab is really, we're hoping the PDUFA date for this trial is by the FDA is at the end of this month. So mirvetuximab would be the first biomarker-directed agent in patients with platinum-resistant ovarian cancer. Put my slide there. Here we go. So the eye toxicities, we've talked about this a little bit. They're off-target effects. So what ends up happening is that the toxin on mirvetuximab is DM4, which is a potent anti-microtubule agent, and it accumulates in the limbal stem cells on the periphery of the cornea. Those limbal stem cells become damaged and they're centripetal, so they actually move to the center of the cornea, and those damaged stem cells look like cysts. So when we either have to hold the drug or dose reduce, it takes about 2 weeks for the stem cells to replenish and the microcysts to go away. So that happens in practice, and we usually see the development of eye toxicities around the time of cycle 2. Ocular steroids can slow down the proliferation of these limbal stem cells, potentially leading to a lower sensitivity of the damaging effects of DM4. So we do 2 things with mirvetuximab, or steroid eye drops, as well as lubricating eye drops to prevent some of the dry eyes that can happen. And these are some of the toxicities. The keratopathy is what the eye specialist, and that could be an ophthalmologist, that could be an optometrist, sees when they do a slit lip exam. And so that there's a lot of different ways of describing keratopathy, which are listed below, but typically it's corneal microcysts. Sometimes you can have a corneal microcyst and that doesn't actually lead to blurred vision, but sometimes there's overlapping corneal microcysts and the patient has some blurred vision, which is intermittent. I mentioned the eye drops. The median time to onset is about cycle 2, as I mentioned. And this is a reversible effect. There's not evidence at all that there are permanent eye side effects. So this is reversible. And only 1 out of 106 patients on SORAYA had to discontinue due to grade 4 keratopathy. So what I don't have here, but are on the slide sets, are really the top line results of SORAYA. So just briefly, eligibility: 106 patients enrolled, all high-grade serous, all having FR alpha high, so that's 75% or higher. All received bevacizumab, and all had received up to 3 prior lines. About 50% of patients had received 3 lines of treatment. We saw an overall response rate of 32.4%, and that was based upon the investigator. That was corroborated by the blinded central review as well. The median duration of response was 6.9 months. So again, that was also corroborated by independent blinded review. There were 2 subgroups in SORAYA. One was the number of prior lines of treatment, 1 to 2 or 3, and then whether or not the patient had received a prior PARP inhibitor. And in neither of those situations did the number of prior lines nor receipt or lack of receipt of prior PARP inhibitor influence negatively the response rate of mirvetuximab of that 32.4%. The other toxicities besides the ocular toxicities are low-grade nausea and low-grade peripheral neuropathy. We saw very few grade 3 or 4 toxicities. with this drug. So it's combinable. It's combinable with bevacizumab. It's also combinable with chemotherapy. But right now, the SORAYA is under review by the FDA for an accelerated approval, and the PDUFA date is November 28th of this year. So looking forward to that. And this is some of the other studies looking at mirvetuximab combinations. So this is carboplatin and mirvetuximab. Number of us in the U.S. Were involved in this, and it's very combinable. The spider plots below show the what happens if there's low, medium, or high FR alpha expression. You can see there are more responders in the FR alpha, but certainly some responders in the lower FR alpha expressions as well. And that's why some trials have actually opened up, especially with combinations, to non-high expressing. The next slide talks about mirvetuximab and Bev. This was presented by Dave O'Malley just at IGCS a few weeks ago. And this trial looked at, on the left, you can see different levels of expression of FR alpha, either low, medium, or high. And I want to be mindful of time. What this showed was an overall response rate of 44%. The levels of expression did correlate with the levels of responsiveness. So the higher levels of FR alpha had a higher response rate, and then lower down for lower levels of FR alpha. And for patients who hadn't received bevacizumab, the levels of overall response rate are a little bit higher. So this is an interesting combination. I think there's another slide. Yeah, these are ongoing trials of mirvetuximab. So there's the Mirasol study, which is on top, and that is the confirmatory trial. This is basically MIRV versus MD choice chemotherapy for patients with, again, platinum-resistant ovarian cancer, high levels of expression of FR alpha. And that'll be the confirmatory trial if an accelerated approval is granted. And then there are others. There's a PICLO trial looking at the effects of mirvetuximab in patients with platinum-sensitive recurrent ovarian cancer. The second is looking at mirvetuximab carboplatin in first-line treatment. Becca Aaron is the primary investigator for this. Number 4 is Gloriosa. This is MIRV plus bevacizumab versus Bev alone as maintenance for patients with platinum-sensitive who are in response to platinum-based chemotherapy. And then the last is actually one that we're participating in. My colleague Gottfried Konechny from UCLA is the overall PI of this. And this is looking at mirvetuximab plus carbo in patients with varying levels of FR expression. So not focusing on high, but focusing on medium as well. And then I think, I'll stop there and answer any questions.
Well, a lot of questions in the chat room, Ursula, about FR alpha staining. Is it easy for a pathologist to do? And of course, the big question: do you see activity when it's low? Is it going to be studied where it's low?
Yeah. So I think if there is accelerated approval granted to mirvetuximab later on this month, if that happens, then there will be potential central labs available to do the FR alpha staining. It would be done within a FDA approved companion diagnostic. But eventually, again, if the drug moves forward with an FDA approval, then yes, pathologists at centers that see a lot of ovarian cancer patients could possibly be trained. But I think it all really depends upon the status of the medication with the FDA. And the answer to the question about, go ahead.
No, go ahead. You go ahead.
No, I was going to say, so Forward 1 is a trial that looked at a different threshold for FR positivity. So it included medium plus high. And what ended up being, Katie Moore was the overall PI of that trial. There was not a statistically improvement improvement in PFS for patients who was treated with mirvetuximab versus MD choice chemotherapy. And that's when we all went back to the drawing board and said, okay, we're going to focus on FR alpha high. And that's what Marisol has focused on. So yes, there are responses, but in the lower levels of FR alpha expression, but they're not as robust when patients have high levels of FR alpha.
So, Debbie, I guess one of the things that's different about antibody drug conjugates, when you're talking about TDXD and HER2 low, they're still trying to figure out how to explain the benefits you see there. But one of the things you hear people talking about are bystander effects that you see with some of these antibody drug conjugates. I'm still not exactly sure how that converts over. Do you really need the marker even, or is this like actually almost chemo? Any thoughts about, this issue of markers in ADCs, Debbie?
I think it depends on the drug, but I do think we see in a lot of antibody drug conjugate trials that in general they will work better when there's higher expression with some outlying things like that TDX2, which, that's pretty amazing, that data that they showed. So we're going to talk about another antibody drug conjugate in a bit. So I think sometimes it has to do with the DAR, the drug antibody ratio, and how much drug is being delivered to an antibody, and also perhaps how stable the linker is that combines the cytotoxic to the antigen, and then also how effective that bystander effect is without having too much toxicity. So, can you get diffusion of the drug into some of the tumor that doesn't have the marker per se, but then also doesn't cause a lot of off-target toxicity then? So those are all the things that we have to maximize in order to have a tolerable ADC that's effective.
So here's another study, similar to the one you were just talking about. I think this is European, again, looking at combining MERV with carbo. To me, it kind of reminds me of, in a way, what happens, what I was mentioning with lymphomas, where they combine an ADC with chemo. I mean, it's real, to me, like, at least these ADCs are delivering chemo, so it's kind of chemo plus chemo. Makes a lot of sense. Any thoughts about these data that were just presented, looking at, I guess, the patients? They looked at all the MERV trials, but then pulled out people who had the longest responses, which I thought was really about 10% of the patients. Any thoughts about the data there? I guess the median duration of response in these patients was like 22 months. Again, I guess it'd be great to figure out what it is different about the longer responders and not. It looked like, I guess, if they got out to a year or whatever, they seemed to, safety-wise, it seemed to, be okay long-term. I was mentioning this other patient who was on for 4 years. Any thoughts, Ursula, about these new data that just got presented?
Yeah, I think, with the dosing starting at 6 milligrams per kilo of MERV, starting there and then having the ability to, dose hold, dose reduce if necessary, you can keep patients on for a long period of time. And I think, this paper, this is presented by Anna Oknen just a few days ago, but it really did focus on those patients who had high levels of FR alpha expression. And, I think for sure there are patients who are going to have, a long period of time on mirvetuximab. And I think probably antibody drug conjugates in general. And again, just obviously good performance status and, not accelerating disease, certainly hitting the target well and having the target present. And then really trying to mitigate and manage toxicities as we give our patients the drug.
I'm still, kind of thinking about the fact this drug is maybe getting approved this month. So I guess it'd be time to start figuring out when to use it and how to use it. But to be continued. Let's talk about the other antibody drug conjugate that we're seeing a lot of excitement about. I like the short name of UPRI, but I'll let you, Debbie, try to tackle the entire name if you want to. But in any event, why don't we start out again with a case? This 72-year-old lady. What happened with her?
Thanks, Neil. So this is a 72-year-old BRCA wild type with platinum-resistant ovarian cancer. She had a CDKN2A germline mutation on panel testing, which is melanoma pancreatic syndrome. Her treatment history was she received 3 cycles of neoadjuvant chemotherapy, then had underwent an interval debulking to 1 millimeter gross residual. then underwent 3 additional cycles of adjuvant carboplatin, paclitaxel, and bevacizumab was added. Her baseline CA-125 was quite elevated at over 9,000. At the completion of chemo, it had come down to 65, but not quite normal. Her CT showed that she was NED. She then went on to receive maintenance bevacizumab for 7 cycles, but this was ultimately discontinued for arthralgias that were intolerable to her. She then had a CA-125 rising, had CT with a measurable disease with a 14-month platinum-free interval. She underwent carboplatin and liposomal doxorubicin, and eventually developed a bowel obstruction and was then sent to us to discuss trials. So she opted for a trial with UpRi, XMT 1536 is what it was called at the time, or upafitamab rilsodotin, but I'm just going to call it UpRi for short. She received 16 cycles. So she actually, I think, is the patient that holds the record for the most treatment ever with this drug. Her best response was actually stable disease. Her CA-125 when she went on trial was 1,446. It did rise to 4,631 cycle 2 day 1. So both of us were a bit nervous about that, but then it actually started coming down, natered at 234, and then gradually rose again to 2,309. She had progression per RECIST. She was dose reduced twice. On cycle 2 day 1, we took her down from 43 milligram per meter squared down to 36 milligram per meter squared. Her AEs in the first cycle were abdominal pain, nausea, fatigue, fever. She wasn't sure she wanted to stay on this drug, but we discussed some mitigation, including dose reducing her, and she opted to stay on and then did quite well. And then on cycle 7, we had to drop her down to 20 milligram per meter squared, which at the time was the next dose for proteinuria grade 2. There's now a dose that's in between at 30 milligrams per meter squared. But the best part of this story probably is that she went on her bucket list trip to Spain during this trial, and she is currently alive with disease still.
Interesting. What's next for her? Did you have an FR alpha level on her, incidentally?
I don't have an FR alpha level on her, but I will get one once mirvetuximab is approved. She is on actually another antibody drug conjugate trial right now.
Really?
They seem to do well for her.
Which one?
It's something that targets cadherin.
Cadherin.
So it's in phase 1. Yeah.
So
doesn't have a name.
You're one of the few. You're one, and incidentally, I knew I remember PMSC from somewhere. It's part of Lynch syndrome. This patient needs a checkpoint inhibitor from before. Anyhow, I'm kind of curious. It's so hard, when drugs first come out, Debbie, to get a feel for like what quality of life is like and et cetera. Overall, it sounds like this woman's quality of life was generally good. You had to deal with some issues. You had dose reductions, et cetera. Is that a typical patient? Or, sometimes drugs come out and all I hear is bad things. So, what's a typical patient in terms of quality of life? Yeah.
Yeah. The first cycle or two can be a little difficult on patients. We're going to go into a little bit, but we are no longer using the 43 milligram per meter squared dose. We're down to the 36 milligram per meter squared, and the quality of life is a lot better on that. It does take some supportive care and some experience. Just like when PARP inhibitors were first released, we didn't exactly know how to, get people through the fatigue and the nausea. And once you get experience with the drug, you get a lot more comfortable with it. So it's manageable. Most patients are able to stay on. You can mitigate the symptoms, manage them, be proactive about it, educate the patient, bring them in, and you can keep them on trial for a while.
As you say, we hear about this every day with newly approved drugs that, after, you hear first from the investigators and then you hear it from the docs in practice, and then usually they figure it out or they stop using it. Well, anyhow, with that clinical background, maybe you can review a little bit about what we know about this agent.
Sure. It's not letting me advance.
Well, let's see. You can just say advance if you want.
If you wouldn't mind, please advance.
Sure.
So this is UpRi. It has a high drug to antibody ratio of about 10, and it has a very stable linker. What NaPi2b is a sodium-dependent phosphate transporter, and it's broadly expressed in ovarian cancer and has limited expression in healthy tissues, which does make it an ideal candidate for an antibody drug conjugate. We do see about 2/3 of patients with high-grade serous ovary cancer do express NaPi2b, and it is a lineage antigen. It's not an oncogene. It actually does, to your point, bring bystander effect, but it gets locked in. So originally it can go to other cells and then it gets locked in. So it starts off as it's an auristatin F HPA, and then it gets locked in the cell as auristatin F, and that's to hopefully reduce toxicity. We call it's a proprietary thing by Mersana called Dololock controlled bystander effect. Next slide. So this was the UpRi phase 1b study, the expansion cohort. It is close to enrollment. We don't have the final results yet, but basically 1 to 3 prior lines in platinum resistant, 4 prior lines regardless of platinum status, enrolled only high-grade serous ovarian cancer. They had to have archival tissue, and if they didn't have archival tissue, then they needed a baseline tumor biopsy. And so while we did not mandate what level of NaPi2b they had to go on, it was retrospectively assessed. And basically in this, we had originally started at 36 milligrams per meter squared. When the dose escalation completed, we hit MTD at 43 milligrams per meter squared, and so that's how we started enrolling patients. However, we had to go back down to 36 milligrams per meter squared after looking at all the data, because actually the efficacy looked better in the 36 milligram per meter squared group than the 43, and had lower toxicity. So basically we did optimization of the dose. And so this is showing the treatment-related adverse events by the dose group. As you can see, in orange is the dose group 36 milligram per meter squared, and on the right is purple, the 43 milligram per meter squared. The most common are really fatigue, nausea. You'll see some transient AST increase. It's really not clinically significant. Patients don't have any Hy's law. We don't have to stop because of it. They'll have transient thrombocytopenia that typically resolves by the time they're due for another dose. And so really, I would say the big things are fatigue and nausea that patients kind of, you have to deal with. And to point out, there is no ocular toxicity actually on this ADC that we've seen, no severe neutropenia, and no neuropathy. So we actually allow patients with grade 2 neuropathy to be treated with this drug. And this is kind of just showing the dose modification where in the 36 milligram per meter squared dose, we only had to dose reduce or delay or discontinue 34% of the patients compared to 48% in the higher dose group. And so really better tolerate the 36 milligram per meter squared. This is the waterfall plot showing the responses again with orange in 36 and purple in 43. And you'll see that the 2 CRs were actually the 36 milligram per meter squared. And we had a third patient whose target lesions did go away, but their non-target didn't quite. So that was a deep PR. This is our objective response rate that were confirmed. So this is broken into both NaPi2b high and then all NaPi2b levels. And so as you can see, it is quite high response rate, very promising, with 34% in the NaPi2b high having a response rate with including 5% CR. And in all NaPi2b, we saw the objective response rate was 23%. I do think part of this was that patients didn't stay on the 43 milligram per meter squared long enough to have a response. And so when we see the final data on this with the expanded 36 milligram per meter squared, I'm hoping that it continues to have a high response rate. Next is Uplift. And so this was our pivotal cohort. Again, platinum-resistant ovarian cancer, 1 to 4 prior lines of therapy. They could have up to grade 2 peripheral neuropathy, again, archival or fresh tissue. If they had only 1 to 2 prior lives, bevacizumab was required, and they could not have primary platinum refractory disease. They got 36 milligram per meter squared up to a max of 80 milligrams every 4 weeks. Next slide. And then finally, up next, which is our confirmatory trial of that pivotal cohort, GOG 3049. This is now actively enrolling. The key enrollment criteria include either complete response, partial response, or stable disease as best response. So I will point out that stable disease, because typically maintenance trials have not included those patients following platinum and recurrent disease. And they can have up to 2 to 4 prior lines of platinum. They do have to be NaPi2b high on this trial. So this is the first time we're mandating that, and that's with a tumor proportion score of greater than or equal to 75. And prior PARP inhibitor therapy is only required if a patient has a BRCA mutation. And they're being randomized 2 to 1 with projected 350 patients being enrolled of UpRi 36 milligram per meter squared up to a max again of 80 every 4 weeks, or placebo. And the primary endpoint is PFS by BICR.
I was just fantasizing maybe someday, like in breast cancer, we'll have a randomized trial comparing one ADC to another. Who knows if we will end up there, but really interesting. I also like the name NaPi2b. It's a lot easier to remember than the letters and all, so that helps out a lot. A couple other papers, again, just more you presented recently, just a couple weeks ago. This looks very practically important in terms of testing our archival material. What did you see there?
Basically, what we saw was a high concordance of NaPi2b status in both synchronous and metachronous samples from the phase 1b UPRI study. And this basically supported the use of being able to use archival tissue for biomarker analysis despite intervening lines of therapy. So in other words, you won't have to get a new biopsy on your patient, no matter how many lines of therapy they've had in the past.
Very important. And here, of course, the question everybody is asking, you can refresh our memories about 2/3 of patients are NaPi2b positive in this other paper.
Correct.
Is it a difficult assay to do, or what is the assay? And are people are going to be doing that as part of this?
So they've been carefully developing this assay over time and trying to learn from past trials. And so they're trying to make it pretty reproducible across pathologists so that it's fairly simple to be able to interpret who is high NaPi2b and who isn't. And I think just like it's, folate receptor alpha is going to be added to a lot of the NGS things as soon as mirvetuximab gets FDA approval. I would suspect that these NGS companies will also be adding NaPi2b. And I would also say that a lot of centers that do their own testing, they'll be able to do the IHC for NaPi2b.
So I'm going to move on now, talk about another research strategy, an ovarian cancer already approved in a couple of tumor treating fields. We actually first got involved with this many years ago. We used to go to the Society of Neuro-Oncology meeting, and when it was coming out and then getting approved for glioblastoma, we did some education programs. It was interesting how people reacted then, and now we're starting to talk about a whole bunch of other tumors. I'm going to be curious what your thoughts are about it. We asked you, Debra, to kind of summarize what's known about this. We added a few other slides in addition, but can you talk about basically what this treatment's unique and unusual treatment strategy is and where you think it might be heading?
Yeah, so basically patients wear a tumor treating field, it's a pad. I'll show you a picture a little bit later in the front and in the back. And essentially it's disrupts the polar molecules and organelles, kind of like what Taxol does to some degree. But basically you get uniform electric field leads to dipole alignment, and then non-uniform electric field leads to dielectrophoresis. And so it's basically kind of a tubulin toxin. Very interesting. Next slide, please. And so this then device was trialed in the Innovate study, which Dr. Vergote presented, and it showed that, again, you mentioned the GBM, and then it's also been used in primary pleural mesothelioma. And it disrupts the formation of the mitotic spindle. And what they found was that overall survival was not reached, but a 1-year survival was about 61%. And the PFS was over 8 months at median, with a PFS at 6 months of 57%, which is pretty impressive in a platinum-resistant ovarian cancer group. And if you want to do the next slide, this is what it looks like. So the patients basically have this little backpack, and they wear these tumor treating fields about 18 hours of a day. And in that particular trial, it's 8 weeks of weekly paclitaxel, and then they go down to day 1, 8, and 15 every 28 days.
Yeah, you would think the paclitaxel would be causing more problems than the tumor treating fields apparatus, which I think mainly you see like sometimes skin irritation from that. I don't think either one of you had a patient who got it, but it is very interesting. You want to talk a little bit more, particularly about this idea of combining with chemo or paclitaxel in platinum-resistant patients?
Yeah, so this is kind of the adverse events that we're seeing. It was a small trial, only 31 patients, but essentially the biggest toxicity was the grade 1 and 2 dermatitis. However, only one patient out of this group discontinued treatment because of dermatitis. One So it was a 6% rate of grade 3 or 4 AEs. And otherwise, if you look at the grade 3 and 4 AEs, it's pretty much what you expect from single agent weekly Taxol at baseline. So it doesn't really seem to add any toxicity other than perhaps the dermatitis.
Right. And this is a big trial that's really interesting. Can you comment on it?
Yes, so this enrollment is actually complete, but this was a NGOT GOG Foundation trial. They enrolled in 540 patients. 60% came from NGOT, 40% from the GOG, and enrollment started back in March 2019. We are expecting some results probably first quarter 2023. They stratified on several different things of no prior systemic therapy following platinum-resistant ovarian cancer diagnosis, 1 prior or 2 priors, also whether or not patients had prior bevacizumab use and what their BRCA status was. And patients were randomized 1-to-1 to either weekly paclitaxel until progression or the tumor treatment fields until local progression with the weekly paclitaxel. And this was open label. There's really no way to do a blinded study when it comes to this. And so they were followed with a endpoint of overall survival, which is why it's not quite yet mature. But we do eagerly anticipate these results.
Ursula, any thoughts about this really unique strategy? It's so different than everything else we have done up to this point in oncology. Any thoughts?
Yeah, I think it's super interesting. Like Debbie said, I really look forward to seeing the results. I think, it would definitely represent another treatment for our patients. They're still getting Taxol here. That's one issue, but I definitely have had a few patients inquire about it, but we don't have the trial open. But looking forward to hearing what goes on.
So I've got to say, in preparation for this webinar, we pulled a bunch of papers. I found some amazing review articles on this topic, particularly, and I'm not even going to ask, to talk about discussing it. This is one that just came out, looking at the mechanism. There's like 22 pages of dense text from discussing the biology, the translational data, a whole bunch of diagrams. Honestly, I don't understand as well as the text, but I will tell you that we are going to get one of these authors on a webinar in the next few weeks and have them explain it, because I'm curious about it. So really interesting. I was amazed. This is a paper that hasn't even been published yet that we pulled that also had some really very, very interesting, a lot of translational work that's been done on this. And now you're seeing more and more clinical work. But anyhow, I want to learn more about it because I think this is really a unique therapy, and whether it's going to really help people, we'll have to see. But certainly such an interesting, different approach to treatment. So let's finish out with, of course, the topic everybody wants to hear about, PARP inhibitors. I want to get your take on the recent, letters to doctors and all the other stuff going on in relapse disease. But let's just start out with the basics. I never get tired of hearing ovarian cancer upfront cases because everyone is different. So let's start out with your 61-year-old woman, Ursula. Any thoughts? Or maybe you can present her.
Sure. So this is a patient of mine who presented with abdominal pain for a few months. And her CT scan, and she went on to have a CAT scan. She had diffuse abdominal peritoneal carcinomatosis. You can see from the arrows. Elevated CA-125. One of our surgeons brought her to upfront laparoscope and deemed that she was not an upfront surgical candidate, but a mental biopsy was done showing a high-grade serous cancer. She underwent neoadjuvant carboplatin paclitaxel intravenously, underwent a successful interval cytoreductive surgery with an R0 resection. She went on to receive additional 3 cycles of chemotherapy and actually had a pretty significant SBO after cycle 4, but completed her 6 cycles of carboplatin Taxol. All of her testing from a genetic standpoint, from a germline and somatic, were negative, but her myriad HRD test was in fact positive. So started her on niraparib, 200 milligrams. Her platelet count did drop from 290 down to 118 about 3 weeks after starting. So I stopped the niraparib and then restarted 3 weeks later, and she's at 100 milligrams. Right now, she's without evidence of cancer. She remains on niraparib 100 a day. and is scheduled to complete her 3 years of niraparib in just a few weeks in February of 2023. And
So a
she's
couple
nervous about coming off.
Yeah, I bet. So many questions come up here. One is, I'm curious about your neoadjuvant therapy. Did you entertain the idea of Bev?
So yeah, I mean, so she went. So no, I mean, up front she was going to go to cytoreductive surgery. So I did not give her bevacizumab up front. Certainly could have given her bevacizumab out back. We did have a conversation about it, and she opted, again, thinking about the impact on OS, impact on PFS, opted not to do it. But certainly could have added Bev. Her myriad HRD test came back positive towards the end of treatment because the tissue from her initial biopsy was not sufficient to send. So we had to wait for the interval cytoreductive surgery to get adequate tissue to send for the myriad HRD. But yes, absolutely could have added Bev.
So Debbie, I'm curious how you generally think through patients like this. Let's talk about the initial neoadjuvant management and then the subsequent management. Any comments?
I mean, I think I do it similar to what Ursula was describing. Oftentimes we'll evaluate kind of the patient's CAT scan, performance status, medical problems, C1.5, et cetera, and decide whether or not we think that they're a good candidate potentially for upfront debulking versus neoadjuvant. And a lot of times we will score them laparoscopically and then make the decision from that. And so, we're probably doing about 50% upfront debulking, 50% neoadjuvant based on all of that data. And then many times we do use carbo and Taxol. Sometimes we do use Bev. That's a little bit more nuance. It comes down to what their germline test is, what their tumor testing is, because we usually just typically send NGS in addition, and then also what their response is, and do they have a lot of ascites and pleural fusions, et cetera. I think now that we have the ability to use both PARP with bevacizumab, it's a little bit easier to go ahead and use Bev with the chemotherapy, knowing that you can add the PARP to it rather than doing switch maintenance, for example.
In terms of adding PARP to Bev, do you still stick with olaparib? There is data, not as much with niraparib. How often do you use the strategy of Bev plus PARP, and do you use either or just olaparib? Debbie?
I would say if I've started somebody on Bev, because in my mind, those decisions are a little bit different. A lot of times they're not always made together. So if I've started a patient on Bev and they come back HRD, then typically I probably would use olaparib, mostly because it's difficult to get anything else approved. But I wouldn't be opposed to using niraparib, bevacizumab. We do have a little bit of data from the Ovarian trial, but that's not FDA approved for that. So if you can get it, it just kind of depends. It comes down to once a day dosing of a PARP versus twice a day dosing, and a little bit differences and maybe some myelosuppression between the two PARP inhibitors. But I think you can use either of those. Likely, we have safety data for sure and some efficacy data as well.
So another really important part of this case, Ursula, is the fact that you are treating her for 3 years, because that's what they did with the niraparib trial versus 2 years with olaparib. So do you just stick with that? It doesn't matter whether they're BRCA mutant or not. It's like when you use niraparib, always 3 years. When you use olaparib, always 2 years. Because I've heard other people say, well, maybe not necessarily, but you tell me.
Yeah, no, I do stick with the trial designs. I agree with you. I mean, I think the PARP inhibitors are, in terms of efficacy, quite similar. But for this patient, I am sticking with 3 years of niraparib just because of the PRIMA data.
Any thoughts on that? I mean, it's a big difference to take a whole extra year of therapy, Debbie. Also, the economic impact. Any comments on that? The other thing I thought was interesting about this case is her platelets dropped even though she was on 200 milligrams. And I'm wondering how often you see that.
Yeah, so I think I do kind of what Ursula does. If I've started niraparib, I'm going to usually use it for 3 years. And if I'm using olaparib for a BRCA patient, I'm typically giving the 2 years based on the SOLO-1 data. I think if you use niraparib for a BRCA1, I wouldn't be opposed to stopping it after 2 years. I think that would come down to a discussion between physician and patient about that. But Ursula mentioned that her patient's nervous about coming off after 3 years. So sometimes we have to talk the patients into why we should stop the drug. And yes, thrombocytopenia is a known issue with niraparib for sure. So it's fairly common that we do have to dose reduce them. Now, when we use the weights and plates starting dose of the 200, we definitely dose reduce them less than when we used to start everybody at 300, but it's not that uncommon to have to dose reduce down to 100 on niraparib.
So I think we'll maybe go on and hear a little bit about Debbie's case of a young patient, 34 years old. Wow, that is really young, but BRCA mutant. So what happened?
Yes, she had a known BRCA mutation, had abdominal pain, 9 centimeter adnexal mass, elevated 725. I was kind of hopeful maybe it wasn't ovary cancer. Unfortunately, I was wrong. So I took her for a diagnostic laparoscopy, saw her right tube and ovary, took that out, sent that for a frozen. And while I was doing my surveillance, saw that there was a little lesion about 1 centimeter on the diaphragm, took that, sent it for a frozen. Both came back cancer. At that point, I XLAP'd her in order to be able to do full, make sure I had resected all gross disease. So did completion surgery, got all the cancer out, put in an IP port on her. She had stage 3B high-grade serous fallopian tube cancer. Post-op 725 had normalized. She got 6 cycles of IP cisplatin and paclitaxel, was NED. I put her on niraparib maintenance about 5 weeks after she completed her chemotherapy. She had some side effects of nausea, GERD, fatigue, kind of the common things. Completed her 2 years, and she's now NED 18 months since completing her olaparib, and 42 months out since completing chemotherapy. And her 725 is under 6 and doing very well.
So IP chemotherapy, that's interesting. Do you do that a lot, Debbie?
I don't do it a lot, but in a BRCA patient, especially young, who I think can handle it, that data is so compelling to me from GOG 172. It's not like I have data on IP chemotherapy followed by PARP, but I wanted to give her best chance of cure. So,
but Ursula, it does make sense. The idea of using IP therapy in a patient with BRCA kind of makes sense, in terms of the platinum. Is that something you do, Ursula?
Absolutely. I would do the same thing with this young lady. Absolutely. I mean, she's a perfect candidate for intraperitoneal chemotherapy. And I would agree with giving her 2 years of olaparib, and she's done super well, which is great.
All right. Here we go. Take your best. Please help us. I don't even know where to begin. Ursula, why don't you take your first shot at what's, I don't even know if I have all the right letters up here, but just tell us what's going on,
Yeah, so I think that the treatment landscape with PARP inhibitors is definitely changing. And it's important for everyone to, kind of keep an eye on all the data that's now coming out about sort of the different treatment or the different clinical situations where you use PARP inhibitors. So what Neil has here are all of the company voluntary withdrawals of basically late line indications, patients who have received 3 or more lines of therapy. So olaparib was withdrawn based upon the SOLO-3 data, showing poor survival for patients receiving olaparib versus non-platinum-based chemotherapy, all BRCA carriers. Rucaparib, based upon Aerial 4, which was presented at ESMO, and that's in both patients with platinum-resistant and platinum-sensitive disease, all BRCA carriers, showing the ITT population OS worse for patients receiving rucaparib versus chemotherapy. That was really driven by the patients with platinum-resistant disease. And then niraparib just kind of fell into line. There was not any kind of randomized trial that showed niraparib performing or underperforming compared to chemotherapy, but because the other 2 PARP inhibitors withdrew, GSK opted to withdraw niraparib as well. And that was based upon the Quadra study, which Katie Moore led. The initial approval for niraparib. Yep.
So I'm going to say, unless you're a Talmudic scholar of ovarian cancer, this is pretty hard stuff to wade through. And I know there's FDA issues and et cetera, but I just want to know for docs in practice, obviously if the approval has been drawn, but where should they be concerned about using a PARP inhibitor where they had been taught to use a PARP inhibitor in the past? The answer, Debbie, that I've gotten when I ask people that is that the most important issue is to avoid, let me see if I have this right, avoid the use of monotherapy of a PARP inhibitor with a recurrent disease in patients who have no, BRCA wild type, nothing, HR proficient. Avoid that. And I'm not too sure about other, like earlier, but so far, do I have that part right?
Yes, you definitely have that part right. What I would say is, in general, patients are getting PARP for maintenance, and I think PARP for treatment is probably just a thing of the past. There aren't going to be very many patients at all that have a BRCA, haven't already seen it. So I would say, in general, we won't be probably using PARP monotherapy for treatment of ovary cancer, but we will continue to use it for sure for frontline and platinum-sensitive ovary cancer.
So I'm going to kind of flip to the other end, not completely the other end, Ursula, but the patient with a platinum-sensitive recurrence, let's say who has BRCA, do you have a concern about using, I know technically there's some data that's concerning, but for practical purposes, if you have a patient like that, are you going to give them a PARP inhibitor maintenance?
Yeah, I think the answer to that, Neil, would be yes, as long as they have not received a PARP inhibitor up front. If they've never received a PARP inhibitor, and you find that they've got a deleterious BRCA mutation, either somatic or germline, and they're platinum sensitive, and they've responded to platinum, yes. And that's really based upon SOLO2, which is all BRCA mutated ovarian cancers, really showing a non-statistically significant 13-month improvement in OS for patients receiving olaparib versus placebo's maintenance. The NOVA study had a trend towards an OS benefit for patients who are germline BRCA positive receiving niraparib versus placebo. Interestingly, we just learned about the Ariel 3 data a few weeks ago. Rob Coleman presented that at IGCS. And that's we're going to have to see that in paper form, but there is not as compelling an OS benefit with rucaparib. And again, it's all subset analysis with rucaparib versus placebo in the BRCA carriers. These studies have been really, there's a lot of issues with crossover. So for patients who were initially placed on placebo, up to 40% in some circumstances, the patients will then switch over to a PARP inhibitor later. And then there's missing data about, some patients with withdrawing issues, withdrawing consent, not having data. We've seen that on NOVA, and that Ariel 3 has a little bit of that. So there's going to be a lot to talk about within these next few months.
Yeah, there certainly is a lot to talk about, and I kind of take it piece by piece to try to, pull out things that will be useful clinically. In any event, Ursula and Debbie, thank you so much for joining us tonight. We all learned so much, and I think the future for ovarian cancer looks really bright. Audience, thank you for attending. Come on back next Tuesday. You'll see what Dr. Carey has to say about HER2-positive breast cancer. Of course, we'll be talking about TDXD, but also HER-Climb, tucatinib, and a lot more. Be safe, stay well, and have a great night. Thanks so much, Debbie. Thanks so much, Ursula.
Take care, Neil. Bye, guys.
Thank you.
Bye-bye. Thank you.
Bye-bye.